Jess Rushing is a new assistant professor in music therapy at UofL with a background in medical music therapy program development, clinical training, NICU music therapy, and acute stroke care research.
Hi, I'm very excited to be here with you all, especially following the introduction on patient experience and making patients happy. I feel like I specialize in that a little bit, but hopefully I can share with you a little bit of the background as to why that might work and why it might happen. I would be remiss if we didn't talk about music therapy and do a little bit of music, so let's do that. I wanted to tell you a story about one of my patients. A lot of times the question that people want to know is, what does it look like? What does music therapy look like? So I thought I'd share with you. So there I was, checking my computer to see what orders I got. I found one in the ICU. A gentleman had been in a motorcycle accident. He was in the intensive care unit, so I went down to the unit. Checked in with his nurse. His nurse tells me that he doesn't do much. He kind of lays there. We've been trying to get him to interact. When he does, he's not aware of his left side. He's had a traumatic brain injury and he's having a bit of neglect on the left side of his body. So I think, all right, let's see what we can do. Can we get him to interact? Can we get him to recognize the left side of his body? So I walk in, and I stand on his right side, because that's his best side right now, right? And he says nothing to me. Okay. His vital signs are pretty normal. Heart rate pretty average. Nothing outstanding. So I pick a song. I guess that maybe he likes country music. And based on his age, which we know your favorite music, or at least the most impactful music, is going to be when you're about late teens to early 20s. Is everyone thinking of their favorite song? Perfect. Anyone like Hank Williams? Even better. So he's not doing anything, I start singing. Hey, hey, good looking, what you got cooking? How's about cooking something up with me? I'm free, I'm ready, so we can go steady. How's about keeping steady company? I got a hot rod Ford and a $2 bill. I know a spot right over the hill. Soda pop and the dancing's free. If you want to have fun, come along with me. Hey, hey. What you got cooking? How's about cooking something up with me? He's not doing anything. Doesn't care about Hank Williams. I'm just kidding, I don't know what he's thinking. So I'm gonna move to the other side of the bed, see if that has a different response. I continue with the song. I'm gonna throw my date book over the fence. Buy me one for 5 or 10 cents. Use it till it's covered with age, 'cause I'm writing your name on every page. Hey, hey. You got it. What you got cooking? How's about cooking something up with me? So he looks exactly the same, nothing has changed. And then with his eyes closed, I hear, "Are you wearing a bikini?" And I'm like, this is great. It's also the perfect opportunity for me to say, I don't know, why don't you look over here and find out? So it did work out that he began turning towards me. So I figured out what his favorite kind of music was. We started singing it. His job was to touch his ear to the side of the pillow towards where the music was coming from, and he did for a good 10 minutes we worked on this. So that's just one example. Let's see how this works. of what music therapy might look like. So we've all heard where words fail, music speaks. I don't think anything is failing, but sometimes we can have the right intervention for the right patient at the right time. So here's an example of a text that I got in November from a social worker on the psych unit at ULH saying that we have a patient that we've been working with and we can't get her to stop crying. And so the physician and the social worker have already worked together and they've decided that they're going to put in an order for music therapy. So now they've communicated with me that we're hopeful that we can have this experience for this patient. I'd already left the building for the day, but we have a full-time intern and part of her rotation is at ULH. So she was able to go and visit with this patient. The patient calmed down, the patient fell asleep. This is just one example that's happened at ULH. And so in 2016, Professor Dintmore ran a survey to see what patients were experiencing when they received music therapy. They found that 100% of people who returned the survey felt that they enjoyed music therapy, that they benefited from it, and that it improved their hospital experience. Some specific ways that they benefited that they identified was reductions in anxiety, increasing in relaxation, comfort, and/or mood. So this is happening widespread. Healthcare systems are recognizing that music therapy can function within the healthcare system as part of the interdisciplinary team. Why might this be happening? We are getting an increasing understanding and technology able to identify what are the mechanisms of music and neuroprocessing that help us understand the impact that it's having on the brain and then the subsequent impact on other outcome measures. So we know that music is a sensory experience. It's not just an auditory experience though, it's a multi-sensory experience. So because of that, it activates multiple brain regions and networks. We know that some of the biggest ones that it activates are attention, reward, emotion, memory. Motor is a large one. A recent Cochrane review of patients who have had acquired brain injuries found that they can significantly improve their gait patterns and different parameters of gait, as well as upper extremity functioning for following stroke, following acquisition of Parkinson's. This is a picture of doing some pre-gait interventions as part of the interdisciplinary team. We've got a physical therapist and an occupational therapist. And we eventually move out into the hallway and we're walking down the hall and we're adjusting the rhythm of the music so that this young woman can increase her balance, work on her stride and her gait. Another area that overlaps a lot with music is language. One of the things that's helping support the higher recognition of music therapy is the media. So you may remember when Senator Giffords had a traumatic brain injury. She had a gunshot wound to the head, and she received music therapy in Texas at the rehab center that she was in. A lot of media coverage with that one. And then a movie was made, and then Ben Folds decided to be our advocate. He comes to all of our conferences now. Celebrities around the nation are visiting Children's Hospital, and music therapy programs are helping organize that and coordinate. That's the Imagine Dragons there. Here's Obama at Walter Reed with his music therapist, Rebecca. They're working on the program there, and they started with one music therapist. Now they have 12 across the nation. And now there's two really large grants funded by the NIH that are supporting further research into the mechanisms. This was launched after a big sound and wellness event at the Kennedy Center last year. So some of the leading hospitals in the nation are now employing, and have been, but there's more coverage recognizing it now, music therapists. This is just a few who made the list. UK Healthcare has a full music therapy staff. Norton has a full staff as well. So what is music therapy? We've touched on different elements of it. There are 5 tenets of music therapy. It is the clinical and evidence-based use of music interventions, often live, so like I did for you here today. And it's accomplishing individualized goals. So I talked about the specific goals that patient that I went to see had. Sometimes we know them, sometimes we have to determine them and run an assessment to figure out what they might be. And we accomplish this within the therapeutic relationship, and it's done by a credentialed professional. One of the things that is challenging about understanding it sometimes is we think music therapy, we think musical goals. We think we're going to play music or you're going to teach me how to play music. It's understandably confusing because a speech and language pathologist focuses on speech and language, a physical therapist focuses on physical therapy. Music is not the goal though, it is the tool. It's not the target, it's the tool. So much more like a psychopathologist or a talk therapist uses verbalizations, uses talk. They're trained in different techniques of talk. is their tool, not their target. We have two main bodies that govern us, the American Music Therapy Association and the Certification Board, and there are about 8,000 board-certified music therapists. To be a board-certified music therapist, you need at least a bachelor's degree in music therapy or the equivalency of that. You get 1,200 hours of clinical supervision, including a full-time internship, which is what we have here between our on-campus clinic and ULH. We train one intern at a time. We also have practicum students that go to the hospitals and to other sites around the community. And you also have to maintain that certification by having continuing education. So again, we have a full academic program at UofL that offers the bachelor level degree. And we offer courses in music. They have to know all their music skills. We have to be able to manipulate the music in real time so that we can do things such as adapt to someone's gait pattern, adapt to the emotions that are being elicited from the musical responses. But we also take coursework in clinical applications of it in special populations. We take coursework in psychology, we take coursework in anatomy and physiology, and we also take coursework in principles and practices and special populations. Across the degree program, you have to do clinicals, practicums and internships, and then as a faculty, we do research. And then we also run a clinic. We have on-campus clinic that people come to us, a lot of folks that have autism, and then we also go out to the community to a bunch of different sites. Just a little recap about what it is and what it is not, as it can be confusing sometimes, is that it is evidence-based. So while it is highly entertaining, hopefully, most often, it is not entertainment. There are a lot of things going on that are underlying that. We work across populations, so again, it's hard to pigeonhole because it's not that you work with, a music therapist works with one type of population. We're trained as generalists, so we are able to eventually specialize in different areas. It's not a person with Alzheimer's that has headphones on their head, as nice as that is. And we often function as part of the interdisciplinary team. You may have heard of bedside musicians or musicians on call or music practitioners. All of these things have their place and have their value. One thing that you are guaranteed with a music therapist, though, is the educational background that I just told you about, as well as standards of practice. So music therapists have a treatment process that they go through for everyone that they work with. It looks different in different settings, but yet nonetheless it is a treatment process, from referral to an assessment to a treatment plan, implementing interventions and techniques, evaluating the effectiveness, and then termination of services. In the hospital, we may only get to see someone for 25 minutes and never see them again, so we do all that on call. We take more of a crisis intervention model, but you might see it happening. It might look like I'm playing you a song, but the choices that I make related to how and why and when I'm playing that song might be related to all of these areas of the treatment process. For example, clinical decision-making involves music logic, so how does the music, and not just music overall, but the different elements of music impact somebody? The rhythm, the tempo, the complexity of it, the instrument that you're using, the accessibility of the instrument. How do I have to shape the music to target the goals that I'm trying to target? We also look at the therapeutic logic, so how am I going to make this relationship with you that's going to be productive? How are we going to drive those goals? We can't do it without the relationship. So that's something that's different than if I'm putting headphones on someone and leaving them there, versus if I am dynamically interacting with you and figuring out what are your strengths and weaknesses and how are we going to move forward together. And then finally, the scientific knowledge. So everything that we do is evidence-based, and we're consistently building our research base. So let's look at some of what that is. A meta-analysis on music therapy versus music in the medical setting has consistently demonstrated that music therapy has significant greater effects than music medicine. So music medicine is going to be passive music listening, often to recorded music. So you'll see a lot of research out there in healthcare settings where they have used some sort of recorded music. There was a recent meta-analysis conducted on pain, which is particularly important here in Kentucky. So we know that music therapy, often with the use of distraction techniques, result in significant reductions of pain, emotional distress from pain, anesthesia use, opiate and non-opiate intake, as well as our vital signs. Here is a specific study that was done on the organ transplant unit. They wanted to look at pain as well as mood. So while pain is significantly being reduced, mood is significantly being improved. So areas such as depression and cheerfulness, awakeness versus drowsy, feeling relaxed versus feeling anxious. So isn't it neat that these are happening simultaneously? So if we get a little further into psychosocial improvements, which is a lot of what we address in the hospital setting, because people are there for a long time, they're away from their things, from their family, they don't want to be there, they're going through painful procedures. So how can we help with their psychosocial needs? One session of patient-preferred live music has demonstrated that they can reduce anxiety and fatigue, stress and relaxation, and have a positive impact on our affect. Multiple sessions had an impact on total mood disturbance. If we want to go a little further into specific interventions for, say, coping, we might do something like patient-preferred live music with coping-infused dialogue. So now we've played your favorite song, and we're going to talk about your experience a little bit and how that's impacting you. What does that mean for you, and how are you going to cope with that across your hospitalization? Or who do you need help from in order to do that? Or what do you need help from in order to do that? So another approach is active music engagement. So I don't know how well you can see that picture, but she's not only playing a song, but everyone is playing with her. So she's passed out musician-proof instruments. You need no skills in order to make music with me. I'm going to give you an instrument that makes sure that that is true. Most of you sang a song with me earlier. I didn't know if you expected to do that or not. So significant improvements, again, in affect, positive and negative affect across one session. A lot of these studies are done with one session because we don't know when we're going to see them again. Also, we have to get them to sign consent, do the session, and do the test afterwards. So let's switch gears a little bit to pediatrics. Two of the strong areas that our research bases in is procedural support. This is also an area that shows some great benefits with cost analysis. So one researcher found that we could completely eliminate the need for sedation during pediatric echocardiograms if you have a music therapist there working with the child from when they walk into the waiting room to when they get the echo and to when they walk out. Not only did it reduce the need for sedative medication, but it also saved 246 staff hours. Because you don't need as many nursing staff, you don't need the anesthesiologist. So per patient, they found that saved $76 in that specific study. The NICU is another area that we have robust research in and that our faculty here has particular expertise in. So a meta-analysis of all of the music therapy NICU research that was done shows a large overall effect size for all of the different interventions that we've run through the NICU. Specific things that we often target are length of stay. So we want to reduce these little ones' length of stay in the NICU. We want to improve their oxygen saturation. We want to stabilize their heart rates. We want to help them gain weight. And sometimes in order to do that, that means that we have to stabilize their behavior states. So we want their neurological system to be functioning well so that they can tolerate the things that are happening to them so that they can eat. And then go home. So non-nutritive sucking and then feeding rate is another thing that we've researched a lot in the NICU. So all of these things collectively have demonstrated large effect sizes. Some additional research that I didn't quite cover today, just for time's sake, but there's a lot related to anxiety. There's a lot related, especially say in the ICU. There's a lot related to rehab techniques. We also do a lot with socialization, decreasing isolation, and normalization of the hospital environment. And of course, pain management is a leading one. These are a couple of interventions that I didn't specifically describe to you, but we do all the time as music therapy clinicians. We might write a song, we might analyze some lyrics, we might make music, we might do music-assisted guided imagery. But what it all comes down to is the patient experience. So these are some quotes from ULH patients when they ran the survey. It brought out emotions from a patient unable to communicate effectively. My mom has been in many hospitals in many states, and I can honestly say this was one of the nicest things any hospital has ever done for her. One of my favorites is that some of the employees joined in and we had to sing along. That just demonstrates to me that it's not just the patient, it's the family, but it's everybody that's involved in the healthcare system. I had the joy of building a program over in California with a healthcare administrator. And she felt pretty good about being able to help start this program and bring this to her patients and her families. But what surprised her, she stopped me in the hallway one day and she said, "Jess, I walked on the unit the other day and the staff was singing." I was like, oh yeah, they probably were. That sounds good. That was so surprising to her that it had such a ripple effect. So even though maybe I or one of our clinicians might be the one most often that's doing the singing or making the music, it is the healthcare system as a whole, so you, the administrators, that help bring these things to the patients and the experience. So I'll leave you with one quick little clip of a patient who'd been in the hospital for a very long time. She had little mobility, little social support systems, and lots of comorbidities. What that says. Oh, it didn't play. She said she was good, but that doesn't matter, does it? She got dressed up for the videotaping. She made the nurse do her hair and put her favorite shirt on. Anywho, this is our faculty over at the university, so we're happy to talk with you in any way that you might need in order for us to help bring this to the patients here at ULH.